I'm here with a cast of speakers and Dr. McGinn and Dr. Sagar, and Tom will do the introductions. I just want to tell this brief story, which is probably close to a year ago. Myself and others tuned in to a grand rounds that was taking place on a Friday morning, almost at this exact time at Virginia Mason. And it was the story of how high-risk breast lesions are managed at Virginia Mason, and work that the team had done on a protocol to help patients be followed over time, as opposed to have everyone have a biopsy. And Dr. Eby and Dr. Quynh and Dr. O'Kelly, Dr. Eby and Dr. Quynh, because Dr. O'Kelly is from somewhere else that you'll hear in a minute, pioneered this work, and we thought it was just terrific, and we felt that it would be an opportunity for us to create a clinical standard for across CommonSpirit, and it was our very first opportunity to do that in the world of clinical standards and variation reduction that Dr. Sagar is leading. So with that, I'm going to turn it over to Tom, and I want to just thank everyone for being here, and also for the folks that have tuned in. I think you're in for an interesting morning. Tom.
Thanks, Gary. I also just want to highlight that this process of creating clinical standards is very difficult to do, but it's something that we're always going to be working on. We're never going to be successful at it, because we're always going to strive to have the best available evidence and practice that in every one of the communities that we serve. But we always have to work towards it. And I think this is an area and a space we have an amazing expertise here. The question of, how do we all come together as experts, agree that this is the approach in a complex, multidisciplinary fashion, and then try to get all of the various moving parts of CommonSpirit to move into this space with the same sense of appreciation for what the current evidence is. So I really think this is such an important effort for CommonSpirit, not just for the breast lesion space, but for all of the things that we do. So I'm going to stop talking like that. Introduce our speakers. We have Dr. Quynh Lee, breast surgeon at Virginia Mason, CHI Franciscan in Seattle. She did a fellowship training in breast surgical oncology at the University of Southern California. Strong interest in women's health, specifically in high-risk breast lesions. Dr. Peter Eby is the chief of breast imaging at Virginia Mason. Did his MD at Vanderbilt, completed residency in diagnostic radiology and a fellowship in emergency radiology and breast imaging at the University of Washington. And finally, we have Dr. Colleen O'Kelly Priddy, who is a board-certified general surgeon and fellowship-trained breast surgical oncologist, medical director of the Breast Cancer Center at Mission Hope's Cancer Center in Santa Maria, California. So that was a mouthful, but we have really good experts with us today, and I'm really excited to hear this conversation. So who am I handing it over to?
Dr. Eby.
Dr. Eby, take it away, sir.
Thank you so much. Yeah, it's a pleasure on behalf of myself, as well as Dr. Lee and Dr. O'Kelly Priddy, to talk to you about this, because we think it's very, very important. We have no relevant disclosures. This is going to be a short discussion that's going to be centered around a single case example. We're going to talk about the indications and process of image-based screening, as well as biopsy, to get us started. And the longitudinal story will then continue with discussion of the institutional data that were reviewed at Virginia Mason Franciscan Health, and how we reevaluated the current clinical practice and changed that. And then Dr. Priddy will finish with the discussion about the broader dispersal of this information and this practice to our CommonSpirit team. So a few important stats, I think, are helpful to set the framework for why we are so interested in this, and it's because breast cancer is so common in this country. Of course, you've heard that 1 out of 8 women are going to be diagnosed with breast cancer in their lifetimes. I do like to remind patients that 7 out of 8 women don't get breast cancer, and that getting a mammogram is actually an opportunity to just confirm that everything is fine, and it's also the opportunity to catch something early if it is there. There will be over 300,000 new cases of breast cancer diagnosed in this country in this year, with 43,000 deaths. And this is why, of course, that we perform screening mammograms, because now we have about 3.7 million survivors in this country, and we want to keep that number growing. What that leads to, of course, is a decreased mortality from breast cancer. There's direct evidence and everybody agrees that screening saves lives, but it also decreases treatment. So women who are diagnosed earlier have less need for radiation therapy, chemotherapy, and less need for mastectomy. And Dr. Lee and Dr. O'Kelly-Priddy are masters at performing partial mastectomies and leaving women in a excellent cosmetic state afterwards. So these are the benefits of screening. And what we know from the national data is that there are cases throughout women's lifetime, and that about 17% of those cases happen in women aged 40 to 49. But you can see it continues to rise with a peak at 60 to 64. And what we also find, though, is that younger women have more to lose, and starting at 40 helps reduce the 27% of overall life years lost to breast cancer for our population. What it's also important to point out, I think, with regards to screening is that we still have some disparities in this country. What we know from the data are that Black women are diagnosed earlier than white women, that they die earlier from breast cancer. They more often have aggressive forms of breast cancer that are triple negative with regards to receptors at twice the rate as white women, and less often ER positive. And what all this adds up to is Black women are 42% more likely to die from breast cancer. So it's even more important to make sure that screening is available to these women and supported beginning at 40. And so our story is going to basically begin with a woman such as this who's 43 years old who gets her first screening mammogram. She's premenopausal. She has no significant family history. So a very common scenario. And on that mammogram, this is 4 views of her mammogram, she has a tiny group of calcifications that cannot be felt on physical exam and only detectable by mammography. And so the radiologist reads this and recalls the patient. She's asked to come back for some diagnostic views so that we can further evaluate those calcifications to determine if they're suspicious or not. These are the spot magnification views that show these calcifications in the upper outer left breast, little tiny calcium deposits that are less than 1 millimeter in size that are seen by the radiologist. And these are considered suspicious, and she's recommended to have a biopsy. And so the radiologist arranges that, contacts the patient, makes sure that she understands what's happening, and brings her in for the biopsy. And when we perform the biopsy, the result for our case is a diagnosis of classic lobular carcinoma in situ. And this is not considered a cancer, but this is considered something that has some risks associated with it. And I am now going to turn it over, as I would in clinical practice. I would refer this patient to the surgeon to then discuss the current management and the recommendations. And Dr. Kelly-Priddy is going to take over here and give us a little bit more information about LCIS and lobular neoplasia.
So the first question that we have whenever we get a biopsy result is always, is there concordance between what we see on the mammogram or ultrasound or MRI and what we're seeing under the microscope on the pathology? And so this is something that's really key in terms of determining what our next steps are. So in this particular patient, the classic lobular carcinoma in situ is deemed to be concordant with the mammographic calcifications that we see. And so then she gets referred to a surgeon, either a general surgeon or a breast surgical oncologist. So here I'm going to take a little bit of a step back and talk about what is lobular neoplasia, what is atypical lobular hyperplasia, and lobular carcinoma in situ of the classic type. So as we know, inside the breast, we have lobules where milk is made, and then milk is carried out through ducts out to the nipple where a baby can drink. And we can move to the next slide. And inside those lobules, when some abnormal cells proliferate, we get distension of the lobular acini, we get distension of the terminal duct lobular units, and this is what we call atypical lobular hyperplasia. It is on a spectrum with the next finding, which is lobular carcinoma in situ. It's essentially the same thing, but it's more extensive and it involves more terminal duct lobular units. And each of these confer a higher lifetime risk of developing breast cancer. It's also important to note that there is no specific mammographic or sonographic finding that is associated with lobular carcinoma in situ or with atypical lobular hyperplasia. As in our patient example from today, we may see calcifications with lobular carcinoma in situ, but that is not always the case. So I want to be very clear about what the scope of our project is here. We're talking about specifically lobular neoplasia, which is atypical lobular hyperplasia and classical type LCIS. There are also other types of LCIS, including pleomorphic and florid, necrotic, etc. Those are not included in these guidelines and recommendations because they behave differently biologically, and so the treatment for them is different. So concordance is really key, as I mentioned before. So every biopsy must have radiologic pathologic concordance documented every time. So the reason that that matters is because the traditional surgical teaching is if you see the word atypia on a core needle biopsy, then you need to take them to the operating room and do an excisional biopsy. But we know that there is actually a lot of variability in what is actually done with the core needle biopsy. As you can see here, there are many different sizes of core needles that are used, the vacuum assisted devices and the larger bore needles, taking more passes and more samples that increases our ability to have diagnostic accuracy before going to the operating room. So when our traditional teaching of if you see the word atypia, there's a 40% or higher risk of finding a cancer on your excision, then that's why we need to go to the operating room. But as we get better data from our biopsies, from larger bore needles and more samples and better pathologic discrimination, maybe we don't actually need to be operating on all these patients. So the reason that all of this matters is because lobular neoplasia is associated with an increased risk of breast cancer in either breast in the future. It is not a precursor lesion like atypical ductal hyperplasia, but it is a risk factor. And the younger the patient is when she's diagnosed, the higher her lifetime risk is. And the more extensive the lobular neoplasia is, the higher her lifetime risk is. So, as I mentioned before, these data are a little bit complicated because our diagnostic criteria have changed over time, but we are able to separate out the more worrisome variants of lobular carcinoma in situ from the ALH and classic LCIS. And so when we do that, we know that the lifetime risk of developing breast cancer is still significantly increased for patients with lobular neoplasia by anywhere from 4 to 10-fold. But does that mean that they need to have this area operated on right away? So this is where I believe we're going to turn it over to Dr. Lee, and she's going to talk about the Virginia Mason experience and review of the data.
Thank you. You can go to the next slide. So at our institution, we began taking a closer look at high-risk breast lesions and asking the question of, how can we improve the recommendations and management to come up with a simpler pathway for our patients? So we first looked at high-risk breast lesions upgrade rates in the literature, and it was simply all over the place. So specifically looking at this, you can see that ALH, the range of upgrade rates in invasive carcinoma or DCIS was 0 to 67%, and the range of LCIS was 0 to 60%. Next slide. So when I was at the University of Southern California and Hoag Hospital, we did a study looking at the specific upgrade rates of high-risk lesions to identify which ones should be recommended for excision. Next slide. This chart here shows our results. So the vertical axis shows that all the core needle biopsies at our institution, and the horizontal axis shows the upgrade rate on surgical pathology. So what we found, you can go to the next slide, was that 7.9% of the time, ALH and classical LCIS were upgraded to invasive carcinoma or DCIS. So 7.9% seemed a little bit high for us. So at Virginia Mason, we examined the literature again. Next slide. So what we found was that lobular neoplasia is discovered in approximately 1 to 2% of all core needle biopsies. The current practice of excising all areas involved with lobular neoplasia on core needle biopsy leads to overtreatment due to the fact that less than 2% of finding a concurrent carcinoma in the same location, and the safety of imaging surveillance and capturing those who ultimately develop carcinoma. So the less than 2% chance of concurrent carcinoma is based on a literature search of peer-reviewed publications that met the following inclusion criteria. So number one, sufficiently powered, so N was greater than 75%. Exclusion of non-classical ALH and LCIS. So what Dr. Priddy was saying earlier, with the pleomorphic or forward LCIS, we excluded those. Exclusion of other lesion which would have required excision, so such as atypical ductal hyperplasia, and making sure that there was adequate radiology pathology correlation with exclusion of discordant or intermediate cases. And finally, we made sure that there was an actual review of the pathology by the study pathologist and not just mere chart review of pathology reports. So when we included these criteria, only 2 studies met the criteria. And so these studies were prospective and had central pathology review and providing the most robust upgrade risk estimate. So these studies show that there's less than 1% risk of upgrade when the above criteria are met. So based off of this, there's an algorithm that we developed at Virginia Mason for lobular neoplasia. So once the patient is diagnosed with classical LCIS or ALH with radiology pathology concordant, she can then have a discussion with a breast surgeon for imaging surveillance at 6, 12, or 24, and 24 months. If the biopsy site is stable for 24 months, then the patient returns to scheduled screening. However, if there are any discordant, then additional high-risk lesion requiring excision or concurrent cancer diagnosed, then the patient will proceed with surgical excision or continued surgical management of the cancer. Next slide. So in this scenario with our 43-year-old patient who is diagnosed with classical LCIS on core needle biopsy, I would discuss with her the option of imaging surveillance and of course surgical excision, and we both will decide together what's best for her. So I'm going to pass it over to Dr. Priddy, and she's going to talk to you about the standard that we've come up with across CommonSpirit.
Thank you. So we can go to the next slide. Okay, so the amazing people at CommonSpirit have created a group for clinical standards and variation reduction. And this falls under the clinical excellence strategic pillar. The goal is to identify high priority clinical areas with evidence-based recommendations and formulate a consensus for what we feel should be the standard of care. And the goal is to improve care and utilization of resources across CommonSpirit Health nationwide. So The big question that we're trying to answer today is, what is the recommended course of action for a patient with an abnormal mammogram results and a new diagnosis of lobular neoplasia, specifically focusing on what is the approach and what should the clinical follow-up be. So we formed a work group, and these are all the people who were involved, and it was a really great experience actually working with all of these people. And we decided that our target audience is really everybody who takes care of these patients with lobular neoplasia. So starting with primary care and gynecology to the surgeons, both breast surgical oncologists as well as the general surgeons, who in many communities are the ones who are doing the breast operations. Also radiology, and then of course, advanced practice providers who are involved with these patients as well. So nationwide, the American Society of Breast Surgeons released a consensus statement in 2016, and the recommendation was no longer routinely excising lobular neoplasia when there is radiologic and pathologic concordance, and when there's nothing else that requires going to the operating room. So another high-risk lesion, or a malignancy, or something along those lines. And so, as such, our new updated treatment recommendations, based on everything that we've just gone through, is that we no longer recommend routine excision of lobular neoplasia when the radiological and pathological diagnoses are concordant, and when no other lesions are present that are requiring excision. So this aligns us with both the American Society of Breast Surgeons and with the National Cancer, NCCN, recommendations. And it avoids overtreatment and decreases unnecessary operations, and also decreases complications from those potentially unnecessary operations. So our conclusion and summary statements are that patients with benign and concordant lobular neoplasia on core needle biopsy have a less than 2% short-term risk of undiagnosed cancer at the biopsy site. So patients can be referred to discuss either the option of surgical excision or imaging surveillance using the modality of detection, as Dr. Lee had described. So it is important to note that pretty much all of these women will now fall into criteria for elevated risk surveillance or high risk surveillance. And so that includes, of course, the annual mammogram, but it also may include things such as annual MRI, which we usually like to do alternating with the mammogram every 6 months, or considering ultrasound if MRI is not able to be done for whatever reason. So patients with lobular neoplasia are at increased lifetime risk for developing cancer in either breast, and therefore part of the surgical discussion should be complete risk assessment and discussion of additional screening options, including MRI, and risk reduction strategies that may include things like chemoprevention. So this is the flowchart that we developed for CommonSpirit to follow where patients should be going based on what their results are. And this is actually available on the Physician Enterprise website, right there. You can see it circled. And it has the flowchart, it has all of the information and a white paper there that we have all, as a group, agreed represents best practices. There also are materials that are patient-facing, and we have smart phrases that surgeons and radiologists can use to make sure that their documentation in care of these patients is as solid as it can be. Thank you very much.
Well, thank you very much. I mean, I think we can maybe start taking some questions from the audience, but I think maybe I'll I'll jump right in. And first of all, thank you guys for this thoughtful, not just the presentation, but all the hard work that went behind this presentation, and to get us to where we are. Can I, let me just ask a very clinical question. I mean, I think when you're at this crossroad, and first of all, the conceptual model of shared decision-making was repeated throughout our conversation. So I think the skill and talent of having that conversation is something that, is something we ought to think about constantly retraining ourselves on how to do that discussion with our patients. When you have a patient and you go through the excision, and you decide to go for an excision, does that change the follow-up in any way? In other words, some of the burden here is, well, if we don't go the surgical route, you have all these, follow-up anxiety that you have to, keep checking. But going through the surgical route doesn't reduce that, does it, or does it? Maybe I'm confused.
It does not. No.
And so I think that's an important, I think that many folks may think, oh, let's get to have the surgery and we'll be done with it, right? So that's sort of not the case. Just maybe you can maybe anyone can jump in, and just help me with that. So you Peter,
from an imaging standpoint, what we're proposing is that if patients prefer not to have surgery, then they're going to come in at 6 months for a mammogram to check the stability of the calcifications. They'll come in 6 months after that, which is 12 months from the original diagnosis, which is when they would come in for their screening anyway. So that's not an added exam, that's an exam.
So you have one added, one at 6 months then, yeah.
And then they would come in a year later, which again would be time for their screening. So the benefit there, I think, is a single additional mammogram at 6 months versus the operation.
Got it. Understood. Thank you.
And I think I understood that to the extent you remove the lesion in question, that doesn't reduce your risk of breast cancer elsewhere in either breast downstream. That it's not this lesion which may turn out to be the problem. It's more of a symptom.
Correct. The risk associated with lobular neoplasia can be in any location in either breast. So just removing the abnormal cells that are right there doesn't necessarily help you.
Yes. I had a question also. I don't think we have any in the chat yet. You spoke at the end about a 20% risk for patients. If people have a 20% risk of breast cancer, they need accelerated screening, and you talked about the different modalities to do that. And I think I know the answer, but I think for the audience, could you talk about where you get the 20% number, Tyrer-Cuzick, and it's not just we ask about your mother and aunts and uncles and aunts and so forth, but it really is a very focused review through using that tool.
So yes, the risk calculation is a critical part of determining the patient's follow-up plan moving forward. So when the patient comes to me, I do a true formal risk calculation, and there are lots of different models that we can use to do this. The most common one we see is the Gale model, and that relies almost entirely on family history. Mm-hmm. The Tyrer-Cuzick model also takes into account the patient's presence or absence of lobular neoplasia and their breast density, as well as their BMI and other things that we know play into their lifetime risk. So this is really important in order to be able to make an informed and appropriate decision when you move forward with the patient. If I calculate her risk to be 40% over her lifetime, then I'm going to pretty strongly recommend annual MRIs in addition to the annual mammogram and potentially clinical breast exams every 6 months. It's a helpful tool to not only inform clinical decision-making, but also for patient education, so they can understand really what it means for them.
I also add one other thing about this cLCIS risk score? So you can Google this online and find it. So it's not something that, you know, you have to buy and it's going to take a while to do. I find that when patients come in, especially new patients to see me, we have them fill out a form and I have all the information and it takes me about 2 minutes to input it in. And then we have this score and it's a much more meaningful conversation.
I think that's because one of my questions was going to be the three of you about, again, you know, if I pick this up and elevate what we're doing, which is really trying to set clinical standards in a complex multidisciplinary space, right? That involves radiology and surgery and pathology and nurse practitioners and physicians, as opposed to saying, you know, hey, we're all going to measure diabetes this way. This to me is, I mean, this is exciting from that standpoint. And I think about all, you know, I can talk about pancreatic cancer management. We can keep going down the line here. And I think having a tool like this that's readily available and we can simply say, hey, this is the CommonSpirit way. We'd love everyone to use this in their conversations. Makes it much, it facilitates this. I guess my question to each of you would be, how do you think your colleagues would feel as you've gone through this process to say, hey, here's our new guidelines, let's all try to follow these? Is there cultural resistance? You know, surgeons want to do surgery, you know, radiologists want to do radiology, you know, there's, you know, I would think of healthcare as very cultural, that's not a judgment. It just is what it is. And we kind of get in our habits and our way of doing things and our comfort zones. How is this being received, you know, both, you know, by your local colleagues, and any thoughts on how this might, maybe Dr. Lee, I would start with you a little bit, like how am I making sense in this question? I don't know. Yeah,
no, I get it. Like, are people, you know, buying in on this, or do we just want to operate? And I think a lot of people are buying in on this. I think people at Virginia Mason, Pacific Northwest, we're excited about this because we want to do what's best for our patient, and surgery is not always the answer. Honestly, if we can avoid surgery, that would be best for them. So I think this gives them another option. Of course, this isn't the option for every patient, but it's good to always have more tools in your bag.
Got it.
Yeah. And Tom, I think that our job now is how we scale this and spread this across the system. And
this is one of the ways we're doing it.
Yes, this is one, but there's others, and that's right.
Order sets and data collection and feedback.
I think
Dr.
what we
Evans,
recognize is also
sorry, go ahead.
I think what we recognize also is that the variability across practices across the country and within the CommonSpirit teams are different. And it will take some time for some people, because as Dr. Kelly Priddy mentioned earlier, the original teaching was, if there is atypia, you excise. And as she also pointed out, the American Society of Breast Surgeons no longer endorses that knee-jerk reaction, but there's some inertia, certainly. I think from a radiological standpoint, it's always been easy to say, oh, atypia, I'm done with this, go to a surgeon. And we don't have to do that anymore, but it will require changing and monitoring patients to make sure that they get the follow-up that they need. It is, you know, again, trusting our surgical colleagues wherever we are, and trusting our pathologists wherever we are to have the concordance that it requires. So there will be definitely need to be some team-related discussions about adopting this.
Yeah, I think also there's a sense of, well, let's just going to recommend excision and I can move on to the next case, versus we're going to work with this person and hold their hand through a process together, which feels a little more complicated. You know, but I think that's, you know, kind of what we need to be doing. So I appreciate that. And I know Gary's, I just realized we have some questions from the audience.
Questions, yeah, we have two. Sorry. No worries. So the first one is from Dr. Gagliano in Phoenix. Good morning, Dr. Gagliano. What is
Dr. Gagliano, Phoenix.
Yes.
All right.
What is the utility of yearly mammogram if yearly MRI is being done anyway?
Yeah, thanks for that question. So I think it's really important when we talk about supplemental screening and how we use them. So, the mammogram is the study that has dedicated randomized controlled trial data behind it to prove that it reduces morbidity and mortality. And so that's always going to be our first line, just because we have those robust data to support it. MRI, we would consider a supplemental screening tool, and so it would generally be considered in addition to the mammogram. There are sometimes things that we see on mammogram, like calcifications, as in this example, which we cannot see on MR. In some of those cases, we will see enhancement on MR, but if we can see them on a mammogram, then that's certainly the cheaper, faster, easier tool. We can certainly do the biopsy using the mammogram without an MRI. But the MRI is something that's considered to be a supplemental tool for patients who are over 20% lifetime risk, because it has the absolute highest sensitivity for detecting breast cancer.
Great. There's an additional question also from Phoenix, Dr. Marcia Gruber-Page. Is genetic testing part of the assessment?
Absolutely. So not all patients with lobular neoplasia will meet NCCN criteria for genetic testing. However, in patients who do have a lifetime risk of greater than 20%, they do often meet criteria for genetic counseling and testing. So that is absolutely another part of the discussion that needs to be had with these patients for shared decision-making.
Great.
Well, Gary, I guess we should wrap it up.
Yes, I think this is great. And someone mentioned, and I think we can close with this, that the process they liked. I don't remember who said that, but just the getting the experts together and working with Dr. Sagar and the team to sort of really flesh this out, what felt like a healthy process. And we have seen that as a phenomenon as we've done more clinical standards work. And we think it's about giving clinicians a clinical voice and an opportunity to practice evidence-based, high-quality care at its best. And so you folks, in a way, were kind of the guinea pigs of that. And I think it really, there's a message here. And so we just really appreciate what you have done. And going back to that very first grand rounds that we saw, we thought there's something here that we need to dig into. And I think it's
a great story. It's a great story.
Thank you so much.
It's a really good story. I love the fact that we saw some expertise and we said, how do we grow this and do best practice with every community? Every community deserves this sort of best practice, right? Wherever you are, in CommonSpirit or anywhere. So this is great stuff. So thank you all again for working on this project, and we'll be calling on you to do more. So
thank you so much.